The following podcast was recorded at the ANZICS Safety and Quality Conference, July 2014, Rapid Response Teams. Ken Hillman talks about the effectiveness of a rapid response service at the hospital level.
Thank you very much, Darryl, and welcome again to everyone. I'm going to start with the word effectiveness and see if I can drill down a little bit on that. So does your hospital need a MET-type system, and is your MET-type system working? Well, you won't know unless you start to do some basic measurements. I'm not saying complex measurements, but some basic measurements. So we can start by looking at your cardiac arrest rates per 1,000 admissions, because that's the way we usually express our terms, per 1,000 admissions. And it should be between 1 if you're quite a good hospital and the MET system's working well, and 6 if you're not so good. And there are some hospitals that are less than 1 these days. And your in-hospital cardiac arrest related mortality, IHCA related mortality, is between 1 if you're pretty good and 5 if you're not so good per 1,000 admissions. So you can start by looking at that. That's pretty easy data to get. And then just have a glance at your deaths and cardiac arrests and see if they were preceded by antecedents, calling criteria, that weren't acted on. So that's a good start to see where you're sitting if you haven't started a MET system, or to see how well your MET system's operating. The effectiveness of your MET system depends on something that I don't think health knows very much about as yet, and that is implementing a new system across a whole organisation. We know a lot about how to implement a new drug, that's easy, or how to implement a new operation or intervention. They're easy things, and we've been doing it for a long time. But I think to implement a system across a whole organisation, I think we're really naive with that particular aspect of things. And I think we've probably got a lot to learn from other sort of industries. I'm not too sure what industries, maybe sort of defence or maybe McDonald's. These people have got ways of having a new system, figuring it out somewhere, and then implementing it in a standardised way across their organisations. For example, we found an extremely wide variation in the merit study that we published in 2005. Some hospitals did really, really well, and other hospitals didn't make a bit of difference. And it was that large variation which contributed to the fact that we couldn't, that the study was inconclusive. A lot of that was due to the large variation in the way people tried to implement the system. Some people did 6 months of good work about, putting up signs all around the hospital. One other hospital sent out emails on the Friday afternoon, started on the Monday. So there's just different challenges with how you implement a system. So we were charged with this challenge when we tried to implement a standardised system across over 250 hospitals in New South Wales. And again, I'm not too sure whether this was the right thing to do, but after talking about it for about 3 months, we decided these are the 5 pillars that we needed to do. The first 2 are easy. We needed a standardised set of criteria. Having said it's easy, it was 12 months of arguing amongst ourselves about what these criteria should be. Then there was the response. That was also pretty easy. But then we included 3 other things, and I believe these are extremely important. It needs to be led by the guy who's in charge of the hospital. That person needs to be accountable, and that's what happened in our state. So the general manager, the CEO of the organisation, was responsible for the implementation, the funding, the support for that system. And then, of course, we had to make sure that everyone was educated, and I'll come back to that in a minute. And then we had to measure what we were doing so we could just track it and see whether we're doing it effectively. The calling criteria, there's been a lot of discussion about this, what sort of numbers we use or scores we use or whatever. I've sort of come to believe over the last few years that it doesn't really matter too much. I think it's more the fact that you now have a hospital where you know that there are sick people in trouble and you need to do something about it. I think that's what the numbers tell us. Whether it's a respiratory rate of 28 or 36, Nowadays, I don't think is as important as you've changed the culture of your whole hospital by having numbers, observations, scores, whatever, that tell you that there's something wrong. So it's a mixture of vital signs and sort of observations such as seizures, decreased level of consciousness. I've got a bit of an issue with scores. I think that scores patronise nurses because it takes away their clinical judgment that's not allowed to be in the score. And I think if you told doctors they had to work by numbers and that they weren't allowed to express any anxiety unless it hit these numbers, I don't think you'd hear the end of the screaming. Experienced nurses have also got clinical judgment. So I'm really not for scores. And I think they make a simple thing very complex. Whether it's electronic or paper-based doesn't really matter either, because one, you've got to type it in, one, you've got to write it in. I can't see too much advantage, but maybe as things get better, that will change. So this is the sort of chart, and you've seen many examples of this over the last couple of days. The response, easy. In our state, we introduced a two-tiered state. There's no data on this to say whether it works or it's better than a one-tiered response, but we're about to collect that data. So the red response is immediate and with people that are trained in acute medicine. The yellow response is the home team with a lower set of calling criteria. So we've had lots of discussion about who should respond. I don't think it really matters here either, as long as they've got three things: the skills, the knowledge and the experience to deal with any medical emergency in a hospital. I think it boils down to that. When we first started our system, we had 2 small country hospitals and we trained the nurses in those hospitals. A 6-month theory course, then they had to do 15 central line insertions, 15 intubations and other skills in the anaesthetic department of those smaller hospitals, and then they sat a 3-day simulation examination and a theory examination. The nurses were the leaders of the medical emergency team, and they weren't the doctors who were doctors that came and went. So they were the leaders. So I don't really think it matters as long as they've got those 3 attributes. And it has to operate 24/7, and it can be a doctor or nurse in 2 hospitals in New South Wales. It's the local ambulance person. These are very small hospitals in remote areas, and in one hospital it's a local policeman. So, as I said before, it's very important that there's ownership and that there's a committee at a very high level that looks at the data, tracks the data, making sure the systems work, making sure it's supported. Education, we agreed on 3 tiers of education. First of all, the whole of hospital. Everyone in the hospital needs to know that this thing exists. 5% of all calls are for non-patients in non-ward areas. So they're in the cafeterias, the car parks, people having babies, people fainting, people falling over, people getting hit by cars, whatever. So everyone needs to know, and everyone needs to be able to press the button for help if they need to. And then there's training of the bedside nurses and doctors, and there's a lot of ambivalence about this. Rob's talking about a 2-day course, that may or may not work. We really don't know. I don't think you can do much more than just make people aware that there are really sick people. These bedside nurses and doctors may be able to look after them. If they're really sick, they may be able to intubate, put central lines in, give inotraps, but probably not. So I guess it's important for the bedside clinicians at least to know that there are people that are seriously ill that need to be looked at very quickly. The responder, we haven't done much work on this, and we probably need to define what the skills and knowledge and experience of the responder should be. We haven't got down to that, but it wouldn't be hard, because you look at all the types of emergencies in a hospital and then you develop the theory and the skills that are necessary to match that responder to the level of illness of the patient. And perhaps we should be doing that one day. Key performance indicators. In my first talk I said I believe these are extremely important to effectiveness. This is how it usually works in health. Everyone in this room collects a lot of data and it sort of goes up somewhere and hardly any of it comes back to the people that actually run the system. We collect crude deaths, cardiac arrests, and we use these two adjectives which I spoke about yesterday. Unexpected, that is all patients minus the ones that are DNR, and potentially preventable, that is if you've got a calling criteria that wasn't acted on appropriately. There's also a very strong correlation between the dose. The higher the dose, the lower the cardiac arrest and mortality rates. So we're moving into a new era with the use of key performance indicators, that if you ask to enter any data, you need to insist that you get the data back to help you with your job of looking after patients. It's got to be relevant to patient safety. It has to be simple, easy, inexpensive, and amenable to continually improving the system that you're running. Is the system effective? Intuitively, it makes a lot of sense that if you're seriously ill, that you intervene earlier and you do better. The scientific support, there's a little bit of that around. It's going to be very difficult to get more because of the large uptake of rapid response systems around the world. It would be very difficult to do one of those conventional randomized controlled trials. So, organisational culture. I've spent 2 years on a study with a full-time research person trying to figure out how culture affects the implementation and the running of a rapid response system. And I can tell you I haven't got very far. There are lots of fancy academic ways of defining culture. It boils down to the way we do things around here, but it's very, very difficult to define. It's very difficult to put your finger on, and every time we tried to do it, it slipped away. So I really haven't got much to offer about culture. I think it matters an awful lot, but it's hard to put numbers on it. It's very difficult. If you've got a royal or a saint or a king or a prince or princess in front of your hospital's name, you'll be slow uptakers, because that's just the way it is, in that you think you already know how to do it, and the system's more rigid. So that's a distinct disadvantage. Maybe if you take one of the names off, you'll do a bit better. Nurses are the key, obviously, and I think this will become increasingly important as we explore rapid response systems and teams and the way they operate, because for one of the first times it empowers nursing staff. Nursing staff have always known there have been sick people that need help, but they've been tied to not being allowed to act on that, and when they do act, they go up a very inefficient hierarchy of interns and residents and registrars and down the other side. So I think this is one of the first times, I think, in hospital medicine that nurses have been empowered to advocate for their patient, not just to stand by and watch them have cardiac arrests and die, but to be a genuine advocate. And I think that's going to be very interesting, especially as we move into an era of sort of continuous monitoring. And I think that will come, obviously, because there's a lot of sick people in hospitals. And I think that will redefine the relationship between nurses and doctors in hospitals in ways that we probably don't know about yet, but will happen. So the hospital of the future, almost the hospital of now, is becoming increasingly a lot of seriously ill, at-risk people, and not many people walking around with dressing gowns anymore. And finally, I'd just like to end up by this quote. This is a man who's famous for developing CPR in Pittsburgh in 1960, but he's also famous for having insights. And he wrote this in 1974, published it in Critical Care Medicine, and it's the most sophisticated intensive care often becomes unnecessarily expensive terminal care when the pre-ICU system fails. This man knew that CPR, okay, that's a good thing, but he also knew that it's much better to prevent these serious events in the first place. I might stop there, Darryl. Thank you.
For more podcasts from ANZICS, go to anzics.com.au.